So, Bismillahirrahmanirrahim. Today's lecture is on thyroid disorders of pregnancy. And the agenda of today's talk will be first a bit about the normal thyroid physiology in pregnancy, the concept of autoimmunity. Then we'll talk about hyperthyroidism, thyroid storm, and gestational thyrotoxicosis. Moving on to hypothyroidism, then postpartum thyroiditis, and how to deal with the nodular thyroid disease in pregnancy. So, normal physiology, thyroid disorders are second commonest endocrine disorders in pregnancy after diabetes, gestational diabetes, right? Pregnancy has a substantial impact on maternal thyroid physiology. Symptoms of thyroid disease during pregnancy may be confused as physiological changes of pregnancy. We all know very well, like palpitations, sweating, tremors, nausea, vomiting. 2 to 5% of pregnancies are really complicated with thyroid disease, but this is a little bit, a figure which is not applicable to all type of population. There are varied kind of prevalences according to geographical areas, ethnicities, and there's a lot of variation related to the iodine content of a geographical area as well. So the important physiological changes which occur during pregnancy, I hope you are very, very aware of this type of graph. I think I've discussed this before as well. The thyroxine binding globulin, that is the TBG, increases in response to the increasing estrogen during pregnancy. And the half-life of this thyroid binding globulin is also increased from 15 minutes to nearly 2 days. There is increase in thyroid stimulatory factors of placental origin, for example, human chorionic gonadotrophin, that is the HCG, which acts like TSH on TSH receptors because of its similarity with the beta chains. The beta chains are all similar. There is decreased iodine availability during pregnancy state and even in the breastfeeding time because the iodine requirement really increases, and the requirement has to be matched to combat with this decreasing availability, and this is because of increased or enhanced excretion, that is increased GFR. So every requirement is increased, right? All types of minerals are raised, calcium requirement, iron requirement, so iodine is also increased. The basal metabolic rate also increases by 25% in pregnancy. So that's the reason the patient can complain of a bit of heat intolerance or palpitations, tremors, sweating, and so on. Coming to the pathophysiology of autoimmunity in pregnancy, autoantibodies have one or more of the following effects, as we all know. That is, they can be stimulatory, they can cause stimulation effect, they can cause inhibition effect, there can be inflammation and destruction. And the autoimmune phenomena follow a precipitating event, which is sometimes after a viral infection, sometimes some radiation exposure. There can be inherent genetic predisposition, like some HLA types are there in the family or in the relatives. And the pregnancy itself can stimulate or precipitate an autoimmune phenomena. Now, how antibodies develop in pregnancy? There is a fetal to maternal cell trafficking going on, right? Fetal lymphocytes, they enter the maternal circulation and act against the thyroid parenchyma. Now, maternal microchimerism phenomena works. The SRY region of the male fetal lymphocyte specifically target the thyroid cells. Now, microchimerism means that there are different chromosomes, right? Fetus can be a male, and his chromosome is different from the maternal chromosome. So here also the SRY region is acting particularly the thyroid cells. That is what they mean to say. More commonly, thyroid peroxidase antibodies occur 10 to 20% pregnancies. So anti-TPO antibodies can be first time detected in pregnancy. That is 10 to 20%. And 50% of these patients then develop autoimmune thyroiditis. So having an antibody during pregnancy is different from having a thyroid disease, which can be autoimmune thyroid disease during pregnancy. There are two different things. So sometimes, gynecology people or even common physicians, they order for autoantibodies or thyroid antibodies during pregnancy due to some reason or so. During pregnancy or before pregnancy in such times, and they turn out to be positive, like as mentioned here, in 10 to 20% cases. Then they come to the endocrinologist asking what to do with these antibodies. So this is a common physiology. One should know that this is part of the common physiology. However, you have to keep an eye on the thyroid function because may ultimately develop the thyroid failure. Now we'll start one by one with all the types of thyroid disorders in pregnancy. Number one here is the hyperthyroidism. Now, symptomatic thyrotoxicosis occurs in 0.2% pregnancies, roughly 0.2%. Again, there is some variation, can be 10 times, can be 2% in some populations. This is difficult to differentiate mild disease from normal pregnancy symptoms, as I mentioned earlier. Elevated total T4 with markedly depressed TSH is usually diagnostic, but you should know how much T4 should be elevated and markedly depressed means it is either undetectable or it is in so much depressed. Depressed means when you say it is less than 0.01 really, but it depends on your assay detection limits. It can be very, very low, like 0.001, 0.0001, so on. So you should know the markedly depressed TSH. What does it mean by? Normal T3 and T4 with depressed TSH indicates subclinical hyperthyroidism, and we don't really treat subclinical hyperthyroidism in pregnancy at all. Remember, no matter what, how much the TSH is depressed, if it is 0.00007 and so on, it doesn't matter. As far as the T3 and T4 is normal, you don't have to treat the subclinical hyperthyroidism in pregnancy. Thyrotoxic patients will have high thyroid stimulating antibodies, that is TRAB or TSI that we call today. And this presence of these antibodies tell you that this patient have autoimmune thyroid disease, that is Graves' disease. And the thyrotoxicosis here means hyperthyroidism here is actually an underlying thyroid disorder rather than the pregnancy phenomena. However, since autoimmune remission occurs during pregnancy, especially in the second and third trimester, symptoms are relieved and you might often have to stop the treatment there or don't treat the patient at all. Propylthiouracil is the preferred anti-thyroid drug compared to methimazole, because methimazole has been reported to cause aplasia cutis and embryopathy, that is choanal atresia. You know, the nasal choana, they become atretic and patient is unable to breathe properly and filter the breath air. Therefore, propylthiouracil is usually preferred, but however, propylthiouracil also has a risk of liver failure in pregnancy, which has a background of FDA warning for it. So it is usually used only in the first trimester. So the recommendations are that propylthiouracil up to 400 milligram per day can be used in the first trimester. Then you must switch to methimazole. That is also a maximum up to 40 milligram per day in the second and third trimester. Both have equal efficacy, but as you know, there are risks relevant to liver failure and the neonatal fetal complications, that is teratogenicity. So you must avoid it. Take antithyroid drug dose just after breastfeeding. This is where they are talking about at the breastfeeding time. So after delivery, or again, if you need antithyroid drug, make sure if you need it, then take it just after breastfeeding so that it does not pass through the milk to the baby. And should provide 3 to 4 hour interval before lactate again. Try to feed the baby first and immediately after feeding, take your drug. And by the time next feeding time comes, at least 3 to 4 hour interval should have elapsed. It can vary, but this is how you can, space out the drug transmission in the milk. Here you can see, this is a picture of aplasia cutis that is on the scalp. There is no aplasia cutis, means there is, cutis means skin and aplasia means no synthesis or no structure. So this part of the skin is missing here on the scalp. This is aplasia cutis. And this is a congenital anomaly of omphalocele you can see here in the baby. Probably the intestine has come out through the umbilical part or umbilical herniation, and probably there is a choanal atresia, because of which the patient is kept in a intensive care and with all those tubings. Okay, so dosage to be adjusted here in hyperthyroidism to maintain the total T4 at 1.5 times upper limit of normal. How do you monitor or adjust? By checking the TSH as well as the T4. Sorry, I should have mentioned that here, but every 4 weeks that should be tested as well. Liver function test should be performed every 3 to 4 weeks in case you are giving propylthiouracil, and the complete blood count to assess the transient leukopenia or agranulocytosis in case of methimazole especially. Subtotal thyroidectomy when severe adverse reactions to medical therapy is seen and there is persistent need of high doses of methimazole or propylthiouracil, or if there is a non-adherence to the therapy, then subtotal thyroidectomy is an option. And whenever you perform such type of elective surgeries in pregnancy, remember second trimester is the time when you can offer it. It is safe usually in pregnancy, and because in the first trimester there is a risk of miscarriage and IUGR because of the general anesthesia, and in the third trimester there is a risk of preterm delivery again because of general anesthesia. So second trimester is usually safe for such a type of elective surgeries. Now, what are the fetal considerations of maternal hyperthyroidism? What can happen to the fetus? Thyroid receptor antibodies, they freely cross the placenta, so there is a risk of fetal Graves' disease. TRAB should be therefore measured by 22 weeks of gestation in the mother. With Graves' disease, any patient who has had Graves' disease, make sure you measure the TRAB antibodies by 22 weeks. If there is a history of Graves with iodine 131 therapy prior to pregnancy, although the patient has had a radioactive iodine ablation therapy in the past and now the patient is under remission, is euthyroid, does not require treatment, but still there is still a possibility of antibody because the gland is there. So you should check and TRAB antibodies by 22 weeks of gestation in such cases. There was a previous neonate who was born with Graves' disease, and there was a previous documented TRAB antibody. So you see, TRABs are so important to assess. If, for example, the patient has been given iodine 131 treatment inadvertently, then you should suggest for abortion or evaluate fetal hypothyroidism. You don't know what will happen to the fetus because radioactive iodine can be devastating, especially in a developing thyroid in the fetus. So all the iodine, the radioactive iodine, will be taken up by the fetal thyroid tissue, and the baby will be born with congenital hypothyroidism anyway. Besides, if it happens in a very, very early trimester, in the early week of pregnancy, then there's even a chance that the growth may not take place at all, and patient can have a miscarriage by natural means, or sometimes you have to suggest medical abortion, medical termination. However, this is legally controversial here, so we don't know what happens really unless we practice such things, God forbid. So always be careful with such patient. Ask about planning pregnancy, ask about whether the patient is pregnant or not in the women of reproductive age group. This is very important. Now, what complications can take place in a patient who is hyperthyroid with respect to the fetus as well as with the pregnant lady herself? So in the fetus, there can be miscarriage, as I said. There can be IUGR, that is intrauterine growth retardation. There can be premature birth, prematurity, there can be placental abruption, and chance of neonatal thyrotoxicosis. Whereas in the mother, there can be preeclampsia, thyroid storm, and high output cardiac failure. Remember, in pregnancy, early pregnancy, if the thyroid is not controlled, especially the Graves' disease, patient has a very high risk of developing thyroid storm. And the death, the mortality of thyroid storm is very high anyway, especially when it comes to pregnancy. So thyroid storm in pregnancy is actually a rare condition. Usually you don't come across such patient because they have such a high mortality that they are either never come into medical attention, or if they do, then there's a very difficulty or very high suspicion required to pick them up. So thyroxine-induced myocardial effects actually happen, and this is often precipitated by the presence of preeclampsia, anemia, and sepsis. So these are the risk factors in a normal pregnancy going on in a thyroid patient, hyperthyroid patient, and if the patient develops preeclampsia for any reason, anemia or sepsis, then there's a chance that there can be precipitation of thyroid storm. How do you treat it? Propylthiouracil as in a non-pregnant state, 200 to 400 milligrams 6 to 8 hourly, either orally or through NG. Then 500 milligram to 1 gram of sodium iodide or 8 drops of supersaturated potassium iodide, that is Lugol's iodine. Dexamethasone 2 milligram IV 6 hourly for 4 doses. This will help in maturity of the patient, of the fetal lung as well. That's why we are giving dexamethasone, and as it can cross the placenta easily and help. Otherwise, hydrocortisone can also cross, but to a lesser extent as compared to dexamethasone, because hydrocortisone can be metabolized by the placental 11 beta hydroxysteroid dehydrogenase type 2. Beta blocker can be given for tachyarrhythmia, preferably propranolol and metoprolol. Now coming to the gestational thyrotoxicosis, which is also called transient hyperthyroidism and is associated with hyperemesis gravidarum. So you see, we often get a consult and a call from gynae and ops people to check the thyroid function in a patient who is admitted with nausea, vomiting, hyperemesis gravidarum actually, and they check the thyroid function, they check the liver function, they call you up as a medical and endocrinologist to come and assess for presence of any thyroid disease. And you have to make a decision and decide if the patient has gestational thyrotoxicosis or actually there is a hyperthyroidism due to Graves or multinodular goiter or whatever. So high serum free T4 or total T4 and low TSH levels are seen, and there is a high beta hCG level, especially because of structural similarity to TSH. So in case you're getting confused, you should check for TRAB antibodies, and you should actually check for beta hCG levels. Although patient is pregnant, and the gynae people would say, why are you checking the hCG? We know that she's pregnant. Why? What is the reason? So you must tell them if the beta hCG is disproportionately very high, because in gestational thyrotoxicosis and hyperemesis gravidarum, if they're very, very high, like 20,000, 200,000, 2 lakhs, then you have to think about 2 important conditions. What are those conditions? Number 1 is hydatidiform mole, and number 2 is choriocarcinoma. So then the whole scenario shift towards ops team. They may have to do an ultrasound scan and to see if the patient is bearing a molar pregnancy, choriocarcinoma, or a normal pregnancy with hyperemesis gravidarum and so on. So this is very important, and it depends on you how much you go for assessment. So gestational trophoblastic disease can also present with hyperthyroidism. That's why I was talking about molar pregnancy and choriocarcinoma. So gestational trophoblastic disease these are the 2 types, right? Molar pregnancy and hydatidiform mole and choriocarcinoma. So patients with hyperemesis should be evaluated for T4, TSH, and TRAB. Antithyroid drugs not indicated in such cases. Beta blockers for peripheral manifestations can be given. Antithyroid drugs are to be given only if the Graves' disease is diagnosed. And how does that happen? If the free T4, total T4 is more than 1.5 times upper limit of normal, okay? If the TSH is markedly depressed, and the clinical sign and symptom of Graves' disease. And what are those sign and symptoms? There's the presence of Graves' ophthalmopathy, presence of goiter with a bruit, and if the patient give a clinical history of, previous history before pregnancy of some weight loss, altered bowel habits, tremors, sweating, and so on, typical, hyperthyroid features. Now coming to the hypothyroidism. Overt hyperthyroidism is defined as high TSH and low FT4, and subclinical is defined as high TSH with normal FT4. You know that. Hypothyroidism has been well known to have adverse outcomes both in the mother and fetus, and I have published a proper, a paper on this topic where I have mentioned about the maternal outcomes, and now another I'm going to publish on the neonatal outcome in a coming days. Treatment is known to improve the obstetric outcome. However, neurodevelopmental long-term effects are not known enough. And there is this CAT study going on in UK and other parts of the world where they are determining the controlled controlled autoimmune thyroiditis study, which is going on, where they are deciding about giving thyroxine for hypothyroxemia and subclinical hypothyroidism, and to see if what are the neurodevelopmental long-term effects on the child. And they are assessing it through IQ level assessment and so on. So this is a very important area of research actually. Potential benefits here actually are more than any risks, so replacement therapy is usually indicated even in subclinical hypothyroidism. Thyroxine requirement in pregnancy is higher than in non-pregnant state. As the woman becomes pregnant, the requirement is 25 to 30% increase in dosage, and this is needed at the confirmation of pregnancy because there is a sudden increase of thyroid binding globulin, right? So all thyroxine is bound with the TBG, and available free thyroxine is less, so 25-30% increment is recommended by the international societies. Usually, hypothyroidism diagnosed during pregnancy is treated with 50 to 100 microgram per. This is a rough dose, but the dose can really vary depending on at what level you want to keep the TSH at. Monitor with TSH and T4 at 4 weeks interval, and dose adjustment with 25 to 50 microgram till TSH is maintained around 2.5 in the first trimester and 3 in around second and third trimester. But now the guidelines have a bit changed, so they have decided to keep it around 2.5 throughout pregnancy. So any dose adjustment depends on the TSH level, and the target should be 2.5 or less rather than 3. Okay. And then soon after delivery, dose reduction is required to the pre-pregnancy dose. A little bit about the iodine requirements in pregnancy. We should know because as I told you earlier in the physiology section that iodine requirement is also increased in pregnancy, and if the daily requirement is not completely fulfilled, then there is a chance of developing thyroid disease itself because of iodine deficiency. So, and it may cause hypothyroidism. So daily requirement is 250 microgram per day during pregnancy and breastfeeding, and it should not increase 500 microgram per day. Fetal and neonatal complications of hypothyroidism are fetal manifestations are decreased school performance in the later life, impaired reading and reduced IQ. Neonatal complications are hyperbilirubinemia, hypoglycemia, respiratory distress syndrome, and cardiac effect. Now, you may be wondering why I have said fetal manifestation, because this is decreased school performance, impaired reading, reduced IQ. Although you assess it in the life after birth, but the causative factor lies at the fetal life. So because brain development takes place in the early part of pregnancy, and once that is completed, that will have an impact on the school performance and reduce IQ in the future life. So you see, at that level, you have to treat it and make sure the iodine and the thyroxine is optimum. Coming to the neonatal complications, I should tell you that my data, my research has so far, concluded that our neonates of hypothyroid pregnant patients suffer more hyperbilirubinemia as compared to the other outcomes, and the reason is not well known. Although there was no ABO incompatibility, there was no other causes of neonatal jaundice like G6PD deficiency and so on. So everything was actually normal and excluded, but uh, most of the neonates had neonatal hyperbilirubinemia for the first 2 to 3 days of life. There was no outcome of complication of hypoglycemia. Respiratory distress syndrome was also there, and there were more cardiac congenital anomaly, especially there was a ventricular septal defect and patent ductus arteriosus. So these are very important outcomes, and they should be kept in mind in patients of maternal hypothyroidism who are pregnant. Congenital thyroid screening is also very important and is usually performed in US and America, US and Europe countries, but here it is still not universally performed. I know that it is being performed at Aachen University, but not here in the Da University. And I encourage my patients whenever I go and see, then tell them that make sure that the baby who is born to this patient has his or her TSH checked after 2 days of birth. So the correct time is at 48 hours of birth, and the range is usually 1 to 20 million international unit per liter. So there is a separate neonatal TSH which has to be ordered, and it's not performed in all laboratories, although there's not much difference with the assays. But because of this range limit and some technicality in measurement, there are specific labs who perform this test. Otherwise, as you can see here, Guthrie test is performed through heel prick, and this heel prick at birth of a neonate can help you screen several other congenital conditions, not only thyroid. Rather, there are other conditions like congenital adrenal hyperplasia, phenylketonuria, and so on. So this Guthrie heel prick test helps in congenital screening of various disorders. Coming to the postpartum thyroiditis, this is usually a transient autoimmune thyroiditis, and it occurs in 5 to 10% of women within 1 year after birth, of childbirth. Women with TRAB antibody and anti-TP antibody before pregnancy are more prone to develop. Obviously, if there is an underlying autoimmune disorder or autoimmune condition, and they are more likely to develop postpartum thyroiditis in the later life. Likelihood of developing postpartum thyroiditis is high in patients with type 1 diabetics and patient with chronic viral hepatitis. Obviously, having an underlying autoimmune disorder increase the chance of any other autoimmune disorder along. 30% chance of eventual permanent hypothyroidism if not optimally managed, or it really depends on the course, and you cannot predict. So you just have to monitor and keep an observation, keep the patient under observation. Also, it is associated with postpartum depression. This is the timeline of phases of postpartum thyroiditis. Usually a thyrotoxic phase usually occur, onset is like nearly 1 to 4 months, and then by the 4 to 8 months, the patient develop hypothyroidism. The thyrotoxic phase is very common as compared to hypothyroid. So there is a 4% incidence, and the mechanism is disruption-induced hormone release. Thereafter, when the hormone is all drained out, the patient becomes thyroid insufficient and they will go on to a phase of hypothyroidism. Symptoms are similar like in any other hyperthyroidism, and in case of hypothyroidism, there can be a goiter and fatigue, inability to concentrate. Treatment is with beta blocker for symptoms in the thyrotoxic phase. So it is a symptomatic treatment. You don't have to give anti-thyroid drugs, whereas thyroxine is required for the hypothyroid phase, sometimes for up to 1 year. For the thyrotoxic phase, which is usually in what happens that 2/3 of the cases become euthyroid and 1/3 develop hypothyroid. And those 1/3 patients, 1/3 become permanently hypothyroid. So you have to, keep on monitoring the patient for 1 year at least. If you are giving thyroxine, after 1 year, you can stop thyroxine and then monitor the patient to see if the patient remains euthyroid with normal TSH after the completion of hypothyroid phase. Sometimes patient remain euthyroid and does not require any thyroxine in the future, but sometimes patient they start developing, start having their TSH rising, then that can give you a hint that, okay, this patient will actually become permanently hypothyroid and may require thyroxine for life. Then you can make a decision. So it depends on how you monitor and observe the patient. Keep the patient bound to yourself, not let the patient get lost to follow up. So it's very important that you educate the patient. This will take time, and only time will tell us how we move. Otherwise, patient get elsewhere, and they are very badly and mismanaged. Coming to the maternal thyroid screening. Now, this is a guideline-based. These are the guideline-based points. American Thyroid Association has described that all patients seeking pregnancy or newly pregnant should undergo clinical evaluation for thyroid screening. And if the following risk factors are identified, that TSH should be performed. So it is still not universally performed in all pregnant patients, but only in those who have these high-risk features. And what are they? Number one is the history of hypothyroidism, hyperthyroidism, or current symptom signs which lead to thyroid dysfunction, which suggest thyroid dysfunction. There is a known thyroid antibody positivity or presence of a goiter, history of head or neck radiation or prior thyroid surgery. If the age of the mother is more than 30 years, there is presence of type 1 diabetes or other autoimmune disorders. There is a history of pregnancy loss, preterm delivery, or infertility. Multiple prior pregnancies. So you see, multi-para patients and of higher age, they are more likely to have thyroid disorders. Presence of family of history of the autoimmune thyroid disease or thyroid dysfunction. If the patient is morbidly obese with a BMI up to 40, and use of eniamidrone or lithium or certain drugs which can affect thyroid dysfunction, thyroid functions, or recent administration of iodinated radiologic contrast, for example, to perform any CT scan and so on. And lastly, residing in an area of known moderate to severe iodine insufficiency. So these are very important risk factors which you should, take in the history of a pregnant patient. Usually, obs and gynae people should do that, but sometimes they can refer to you, assessing such history, that look for some medical evaluations, medical screening required. So you should ask them. Now, coming to the last part of our topic, that is the nodular thyroid disease. Small thyroid nodules are again a common phenomenon in pregnancy. As we all know that the pregnancy goiter is also a physiological response. So arrival of small thyroid nodules can also be normal. Some studies suggest these nodules can turn malignant, and diagnosis mainly by sonography, that is ultrasound and FNAC. So when should you go for an FNAC in a pregnant female? If the nodule size is more than 1 centimeter, then you should definitely go for FNAC in all patients, regardless whether they are pregnant or not. And if the FNAC, if the ultrasound shows the size of 5 millimeter to 1 centimeter, but with suspicious or high risk history or features in ultrasound, then you should also perform an FNAC. So whatever the indication or reason for FNAC in other nodular disease, thyroid disease, are the same apply to the pregnant state. So these are the high risk features or suspicious features where the ultrasound, and there is the estimated risk of malignancy, and FNA size cutoff is also mentioned here. Again, they are from the American Thyroid Association. And you can see that if there are high suspicious features or intermediate and low suspicious, then the recommended size is for FNAC is more than 1 centimeter. But if there are low suspicious features, then FNA cutoff is more than 2 centimeter. Okay, so if the size is if there are low suspicious features but size, then you have to see size. If it is 1 centimeter, then it's okay. But if it is more than 1 centimeter, then you must think about the size. And if it is more than 2 centimeter, then decide about doing an FNAC. In case the features show benign category like purely cystic nodules and no solid component at all, then biopsy is not required regardless of whatever the size is. Now, if the nodules are detected early, then you have to make a decision and look for other features. If there is a suspicious cytology, if there is a lymphadenopathy, and if there is a rapid growth, or if there is a prior bad history, then you have to make a decision for surgery. As I told you earlier, the surgery during pregnancy is usually performed during the second trimester, after which it can stimulate the preterm labor or preterm delivery. So the best time for performing surgery is second trimester. If nodules are detected in the third trimester, then you can easily defer the surgery after delivery and wait. In case the patient has got a papillary or follicular carcinoma on FNAC and are relatively slow growing, then again surgery can be delayed and there is no hurry in that. And if so, then again that can be performed during the second trimester. Radioiodine therapy at least 4 weeks after cessation of breastfeeding and the lady asked not to conceive for 6 months to 1 year. So the radioiodine treatment part of for the thyroid carcinomas is definitely not considered during pregnancy, neither in the postpartum phase when the patient is breastfeeding. I think up to around 2 years, the breastfeeding time. Once the mother decide or the lady decide to stop breastfeeding the baby, then you have to wait for another 1 month and then allow the radioiodine therapy to take place. Why? Because again the breast tissue has become so primed with all the receptors that if you give the radioactive iodine during breastfeeding or immediately up to 1 month after breastfeeding is stopped, then all the radioiodine contrast will be jammed up in the breast tissue rather than in the thyroid tissue. So it is important that the breastfeeding stops and 1 month has been elapsed for it to go back to normal structure, so that the radioiodine contrast, when it is given for the treatment purpose, goes to the cancerous thyroid cells rather than the normal tissue of the breast. Now let's brainstorm through the few cases. This is case number 1, that is 30-year-old woman with first pregnancy, 8 weeks, diagnosed with Hashimoto's 5 years ago, is on levothyroxine 125 microgram per day. Last TSH is 3.4, which was performed 6 months back. Now she's 8 weeks pregnant. So what do you recommend further? So increase the dose by 25 to 30%. Okay. Next case is case number 2, that is 22-year-old woman with type 1 diabetes, unplanned pregnancy. Now she's 6 weeks pregnant. TSH is 4.1, FT4 is 13. Would you start thyroxine? Because of the presence of type 1 diabetes, she's prone to develop another autoimmune disorder. That's why the presence of TSH at 4.1 can be risky. But here the correct decision would be to, check for antibodies and then decide whether the patient really has autoimmune disease. And if that antibody turn out to be positive, then you must start this patient on thyroxine. If the antibody is negative at this TSH, then you can just observe the patient with TSH on a monthly basis, 4 weeks interval. Okay. G. If the antibody is negative. Okay. Now coming to the case number 3, 36-year-old woman, third pregnancy, now 11 weeks pregnant, seen by OBS people with hyperemesis and admitted for treatment. The TSH is 0.016 and FT4 is 26. Now how to proceed? This lady is still in her first trimester and has presented with hyperemesis, right? And the thyroid profile clearly show there is hyperthyroidism because FT4 is quite high. It's like more than 1.5 times. So there is a possibility that she may have Graves' disease. If you have all the facilities available, then you must proceed with, again, antibody check. First, you should check for clinical history, any previous history of Graves' disease or features related to, having a neonate with a Graves' Graves' disease and any past history of goiter and so on. If you don't have any such history, just check for TRAB antibody. If TRAB antibody is positive with such thyroid profile, then this means that patient actually has Graves' disease, and you may start on PTU because she is in her first trimester. If the TRAB antibody is negative at this point, then again you can treat the patient symptomatically with beta blocker, adequate hydration, antiemetics, and so on, and then monitor with the thyroid functions. So PTU start nahi kar, we won't start with PTU if the antibody is negative and there is no clinical, clue that the patient may have Graves. Like there is no eye disease, there is no goiter with any bruit, there is no pre-pregnancy feature of clinical sign and symptom of Graves. Okay? Then you can take the risk of, not. हाँ, बिल्कुल. And you will check the total T4 here to see if it is still 1.5 times upper limit of normal. You will not try to treat this patient. Moving on to the next case, that is case number 4, that is 40-year-old woman, 4th pregnancy, which is also unplanned, referred for evaluation of Graves' disease. Previously treated for Graves' disease with vague history, no medications at present. TSH is less than 0.014, FT4 is 29 and FT3 is 9. So what should be done now? It's almost the similar scenario, but here they have takriban milta julta hai. But here they have given you age factor and pointed you out with respect to the previously treated for Graves' disease with vague history. So there is a doubtful previous history. And as you can see, this is a 4th pregnancy, multiparity, higher age, with higher chances of complication. Then here you may take the risk of treating the patient. I mean, take the decision of treating the patient because there's chance that patient may have this is an unplanned pregnancy. So again, the best course of action would be to check the antibodies. Because there was a previous treatment for Graves, it's better that you check the antibodies. If they turn out to be positive, then you must treat. हाँ, किस चीज में? So, case number 5, I hope this is the last case. 26-year-old lady with gestational amenorrhea of 12 weeks. Comes with a complaint of weight loss, sweating, palpitations. No history of vomiting or diarrhea. On examination, there is no goiter, no eye signs, no tremors. TSH is 0.005. T4 is 9.9 and T3 is also normal. What to do next? Now, this case is most of the cases are similar. They are all similar cases with this thoda sa isme there is a differences in how they are presented or how they are explained to let you decide on various points of managements. Again, here there is no clue of any intrinsic thyroid disease, right? There's even no sign and symptom. There's no weight loss, no sweating, no palpitation, nothing. But the thyroid profile is abnormal, so the patient might have been referred to you for further management. Then what to do next? Would you like to proceed for beta HCG because patient has no symptomatology at all? There is a history of weight loss, sweating, palpitations. Again, these tests show that the TSH is quite suppressed, but you see the T4 is normal, is in the normal range. It is not more than 1.5 times upper limit of normal. G. So this is, if you see the thyroid profile, this is subclinical hyperthyroidism. And this is subclinical. And the TSH is low here because of beta HCG. So you won't treat this patient with antithyroid drug. You just monitor, treat the patient symptomatically. So here we will just move on to checking the TRAB antibody, just to exclude any presence of any grave disease or underlying thyroid disorder, but this is not really required for the treatment decision purpose, because here we see that the TSH is quite suppressed, but the T4 is within the normal range, and unless this is more than 1.5 times upper limit of normal, even after having an antibody positivity, we won't treat this patient with an antithyroid drug. So we'll just keep her on observation. So the treatment decision here based on T4 rather than antibody. Thank you very much for your kind attention.